Good day. This is my lecture on high-risk pregnancy, and this is Doc Ina. To download my lecture deck, please go to my WordPress site, Ina Obigaine. And here are the references for this lecture. And this is the outline of my lecture. The major goal of prenatal care is to help ensure the birth of a healthy baby while minimizing risk to the mother. The components involved in achieving this objective are the following: early and accurate estimation of gestational age, identification of pregnancies at increased risk for maternal or fetal morbidity and mortality, ongoing evaluation of maternal and fetal health status, anticipation of problems with intervention if possible to prevent or minimize morbidity, and health promotion, education, support, and shared decision making. So as you can see, it is one of the goals of prenatal care to identify high-risk pregnancies. Risk assessment is part of routine prenatal care, and risk factors are assessed systematically because each risk factor that is present increases the overall risk in pregnancy. High-risk pregnancies require close monitoring and sometimes referral to a perinatal center, especially if women have complex high-risk conditions. These centers offer many specialty and subspecialty services provided by maternal, fetal, and neonatal specialists. A high-risk pregnancy involves at least one of the following. First, the woman or baby is more likely to become ill or die than usual. And second, complications before or after delivery are more likely to occur than usual. High-risk patients require sophisticated maternal and fetal surveillance and in many occasions, difficult management decisions in order to optimize their outcomes. A pregnancy is defined as high risk when the probability of an adverse outcome for the mother or child is increased over and above the baseline risk of that outcome among the general pregnant population by the presence of one or more ascertainable risk factors or indicators. Some conditions may require the involvement of a maternal fetal medicine subspecialist, a geneticist, a pediatrician, an anesthesiologist, or other medical specialists in the evaluation, counseling, and care of the woman and her fetus. So here are some examples of high-risk conditions. So women with cardiac disease, diabetes mellitus, women with a family or personal history of genetic abnormalities, hemoglobinopathy, chronic hypertension, renal insufficiency, pulmonary disease, HIV, prior pulmonary embolus or DVT, severe systemic disease, bariatric surgery, epilepsy, and cancer. We also include as high-risk conditions women who have CDE or other blood group alloimmunization, women with prior or current fetal structural or chromosomal abnormalities, desire or need for prenatal diagnosis or fetal therapy, periconceptional exposure to known teratogens, infection with or exposure to organisms that cause congenital infection, women with higher order multifetal gestation, and severe disorders of amniotic fluid volume. Of course, there are other high-risk conditions that may not be listed in this table. So in the next few slides, we'll talk about these high-risk conditions in more detail. So first, existing maternal health conditions. So some of the existing maternal health conditions that put the pregnancy at high risk include the following: hypertension, because it puts the patient at risk to develop chronic hypertension with superimposed preeclampsia, and this may also cause fetal growth and amniotic fluid disorders, and it also puts the patient at risk for preterm delivery and cesarean delivery. Diabetes puts the patient at risk for developing pregnancy-induced hypertensive disease, fetal growth disorders, amniotic fluid disorders, and cesarean delivery. Kidney disease puts the patient at risk for preterm delivery, low birth weight, and preeclampsia. Autoimmune diseases puts the patient at risk for preeclampsia, miscarriage, preterm birth, and stillbirth. And of course, certain medicines to treat autoimmune diseases may be harmful to the fetus. Thyroid disease can also cause problems for the fetus such as heart failure, poor weight gain, and brain development problems. Malnutrition, and more specifically obesity, puts the patient at risk for fetal growth disorders, and obesity is also a risk factor for the development of GDM, pregnancy induced hypertension, and cesarean delivery. Next, we have maternal age, and more specifically, we are talking about advanced maternal age at first pregnancy and teenage pregnancy. According to the WHO, at least 10 million unintended pregnancies occur each year among adolescent girls aged 15 to 19 years old. Complications during pregnancy and childbirth are the leading cause of death for adolescents 15 to 19 years old. Of the estimated 5.6 million abortions that occur each year among adolescent girls aged 15 to 19 years old, 3.9 million are unsafe, contributing to maternal mortality, morbidity, and lasting health problems. Adolescent mothers aged 10 to 19 years old face higher risk of eclampsia, puerperal endometritis, and systemic infections than women aged 20 to 24 years old, and babies of adolescent mothers face higher risk of low birth weight, preterm delivery, and severe neonatal conditions. Teenage pregnancy is usually associated with history of risky behaviors such as smoking, alcohol consumption, drug abuse, sexual promiscuity, mental health problems, or a history of adverse childhood experiences. Associated medical complications include preterm birth, low birth weight, perinatal mortality, short interval to next pregnancy, and sudden infant death syndrome. Pregnant adolescents are at high risk for nutritional deficiencies, anemia, HIV infection, and other STIs. And there's also a very high incidence of pregnancy induced hypertension among teenage pregnant mothers. There is also a possibility of a competition for nutrients between the fetus and the mother, and this could affect pregnancy outcome in adolescents by interrupting the normal growth process. And of course, there's also higher incidence of cesarean delivery among teenage pregnant mothers. For advanced maternal age, this means that the maternal age is 35 years old and above at the time of first pregnancy. And these patients have high risk for spontaneous miscarriage, ectopic pregnancy, stillbirth, chromosomal abnormalities, multiple gestation, hypertensive disorders, gestational diabetes, operative deliveries, placenta previa, and low birth weight. The increase in congenital anomalies with advancing maternal age has been attributed to the recognized increase of aneuploidy with advancing maternal age and the association of aneuploid fetuses with structural anomalies. Also, cardiac anomalies seem to increase with maternal age independent of aneuploidy. Next, we have lifestyle factors. And these lifestyle factors include the following: alcohol use, which puts the patient at risk for fetal alcohol spectrum disorders, sudden infant death syndrome, and other problems. Fetal alcohol spectrum disorders may lead to intellectual and developmental disabilities in the child, also potential behavioral problems, abnormal facial features, and disorders of the heart, kidneys, bones, and hearing. Next, we have tobacco use or smoking, which puts the patient at high risk for preterm labor and delivery, birth defects, and sudden infant death syndrome. Secondhand smoke also puts the woman and her developing fetus at increased risk for health problems. Drug use puts the patient at high risk for stillbirth, and smoking marijuana during pregnancy can interfere with normal brain development in the fetus, possibly causing long term developmental problems. Next, we have pregnancy conditions, and this includes multiple gestation, which puts the patient at high risk for preterm labor and delivery, postpartum hemorrhage, preeclampsia, and fetal congenital malformations, and of course, cesarean delivery. Also included in this list will be gestational diabetes, which puts the patient at risk for developing or for having preterm labor and delivery, fetal growth and amniotic fluid disorders, and preeclampsia. It also increases the risk that a woman and her baby will develop type 2 diabetes and later in life. Previous preterm birth puts the patient at risk for preterm labor and delivery, and birth defects or genetic conditions in the fetus. So, knowing a fetus may have birth defects before birth can help healthcare providers and parents be prepared to give treatment right away after delivery. Pregnant patients with known fetal growth disorders or amniotic fluid disorders may need frequent antenatal surveillance tests. Also included in this list will be patients with placenta previa or known placental abnormalities and patients with exposure to teratogens. And then finally, we also include in this list patients who are grand multipara. And a grand multipara is a patient who has had at least 5 births, live or stillborn, at more than 20 weeks of gestation. And we also have this term called great grand multipara, which is a patient who has had at least 10 births, live or stillborn, at 20 weeks age of gestation. Grand multiparity increases the risk of the following complications. So, these patients may have placental abnormalities such as placenta previa and abruptio. They may also experience postpartum hemorrhage, develop macrosomia, or the patient may have a fetus with umbilical cord prolapse. Next is poor obstetric history. And this is a maternal history of recurrent pregnancy loss, fetal death, a history of birth defects or congenital malformations, patients who had a history of preterm delivery or birth, or patients with a history of low birth weight or macrosomic babies in previous pregnancies. And lastly, we have a gynecologic history. So this usually pertains to a history of uterine septum or didelphys, patients with incompetent cervix, patients with previous uterine surgery, patients with a pelvic tumor or malignancy, or patients with infections. So, how do we manage high risk pregnancy? So, one of the best things to do for this high risk women will be to do preconception evaluation and counseling. However, not all women will come to you for preconception counseling. So most of these patients will come to you already pregnant. So during their first prenatal checkup, do screen for those high risk factors that we've already mentioned in the previous slides. And once you've already identified a woman or a patient to be or to have a high risk pregnancy, then please refer this patient ASAP to a perinatologist or a maternal fetal medicine specialist. You can also request or do screening tests to identify fetuses at high risk for aneuploidy if indicated. We can also refer these patients to a geneticist for genetic counseling. And of course, it's very important that you initiate lifestyle modification and nutritional counseling. Of course, part of the management would be to do antenatal surveillance tests. Okay, so the appropriate initiation and frequency of testing is determined by the indication for the test as well as gestational age. And typically, the testing is done or begun at 32 weeks AOG. Some experts would say 28 weeks AOG. And this is performed on a weekly or twice weekly basis. However, maternal or fetal situations may dictate more frequent testing, such as 2 or 3 times a week or sometimes even daily testing. So here is a table that very nicely summarizes the frequency of fetal surveillance or antenatal tests. Now, the basic formal testing scheme here would be the modified BPP, okay? Or we can also do the full BPP. Okay, so for example, for postdatism, then we initiate antenatal tests at 41 weeks or earlier if EDD is unsure, and we do this twice weekly. For hypertensive diseases, preeclampsia, we initiate at antenatal test at diagnosis, and we do this twice weekly. For chronic hypertension, we initiate antenatal test at 32 weeks, and we do this weekly. For patients with GDM, that's diet controlled, the recommendation is to just advise patient fetal kick counts. If she is on insulin or oral hypoglycemic agent, then we start fetal surveillance test at 32 weeks, and we do this twice weekly. If the patient has pregestational diabetes without complications, meaning she has good sugar control, then the initiation of antenatal test would be around 32 weeks, and we do this twice weekly. However, if she has pregestational diabetes but with poor sugar control, then the initiation of antenatal test or fetal surveillance will be earlier at 28 weeks, and we do this twice weekly. For patients with advanced maternal age, greater than or equal to 40 years old, initiation of fetal surveillance test will be at 32 weeks, and we do this weekly. For patients with severe maternal conditions such as a gravidocardiac, those with pulmonary disease or severe asthma or sickle cell anemia, the initiation of fetal surveillance would be around 32 weeks, and we do this weekly, or we can do this more frequently if indicated. For patients with SLE or antiphospholipid antibody syndrome, initiation of fetal surveillance is at 32 weeks, and we do this weekly or more frequently if indicated. For patients with thyroid disease that's uncontrolled, we initiate a fetal surveillance test at 32 weeks, and we can do this twice weekly. For maternal Graves' disease, the initiation of fetal surveillance test would be at 36 weeks, and we do this weekly. For patients with HIV, okay, on combination treatment, the initiation of fetal surveillance will be at 32 weeks, and we do this weekly. For patients with oligohydramnios, no, we initiate the fetal surveillance at diagnosis, no, when we diagnose with the oligohydramnios, and the frequency is as indicated. Okay, some authors would recommend every 3 days or twice weekly or sometimes weekly. For patients with IUG-RBBs, no, the initiation of fetal surveillance will be at diagnosis, and the frequency will be twice weekly. For twins with dichorionic diamnionic placentation with normal growth and normal amniotic fluid volume, initiation of fetal surveillance test will be at 32 weeks, and then we can do this weekly. However, at 36 weeks, the frequency will be around twice weekly. For twins with monochorionic diamnionic placentation with normal growth and concordant or normal amniotic fluid volume, initiation will be at 28 weeks, and we can do this weekly. However, starting 32 weeks, the frequency will be twice weekly. Okay, so for fetuses with certain abnormalities such as CDH, gastroschisis, persistent echogenic bowel, or increased nuchal translucency, then the fetal surveillance test can be initiated at 32 weeks, and the frequency will be weekly. Okay, so, and all the rest, you can just refer to this table. So that's it for my lecture. So in summary, we have discussed the definition of high-risk pregnancy. We also talked about some examples of high-risk conditions or risk factors that make a pregnancy at high risk. We also talked about how to diagnose high-risk pregnancy, and finally, how to manage high-risk pregnancies. Thank you for watching this video lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Abigayle. Thank you.